we don't have a whole lot of data on how drains perform. We know they get coated with biofilms very early after insertion, but we're looking forward to hearing this paper. So welcome, Dr. Sherdhani. Thank you. Congratulations.
Thank you, sir. I appreciate it.
So this is your advance right there.
Sure. Well, congratulations to my co-resident in the winner category as well. My name is Sachin Shridharani, and I'm honored to present and thank you all for giving me the opportunity to present evidence-based medicine versus experience-based medicine in plastic surgery, the role of antibiotic prophylaxis in patients with closed suction drains. I have no conflicts of interest or financial disclosures to report at this time. The utilization of closed suction drains in the postoperative period is incredibly well described. These drains are placed to decrease pathologic fluid collections such as seromas and hematomas, and certainly those fluid collections can in fact be a devastating complication for the patient and of massive concern for the surgeon. There is an ongoing debate in the literature, however, if first of all these drains do in fact decrease the incidence of these fluid collections in certain plastic surgery procedures. But even furthermore, when in fact they are placed, what can be done to decrease the possibility of an infection in those patients? And it seems that this is an area in plastic surgery where experience-based medicine or anecdotal data can in fact be challenged by what the evidence shows us. When closed suction drains are placed, it's very common for plastic surgeons and other specialties as well to place patients on prolonged antibiotic therapies. Now, this is often done because of the myth that's been perpetuated for years that retrograde bacterial migration through the drain will in fact colonize the surgical site and in fact also colonize the fluid collection that could be potentially present in that surgical site. Critically evaluating the literature shows us, however, that when we've looked at these studies, that usually the microbe that speciates from the actual surgical site does not in fact correlate or is not the same bacteria that's found in the JP drain reservoir, the hemovac reservoir as well. So this myth in fact has actually been dispelled, that retrograde migration actually occurs and is the same bacteria. We also know from the Center for Disease Control, National Institute of Health, and other organizations that the sequela of placing patients on unnecessary antibiotics certainly selects for multi-drug resistant bacteria. So the aim in particular was to provide evidence from the scientific literature to elucidate or negate whether closed suction drains are in fact warranted, but furthermore for this particular study to compare the evidence versus what the experience of individuals is with respects to antibiotic prophylaxis in closed suction drain placement and dispel that myth. A systematic review of the literature was performed searching the four most common and largest databases, and the mesh search terms are listed here. The combination generated the relevant articles and the studies, which were independently evaluated by 3 reviewers, and 100% agreement was found upon those 3 reviewers to see which studies should in fact be included. Also, we wanted to have only the highest quality studies in our actual systematic review. Therefore, level 1 and 2 studies and very large retrospective reviews were included. Smaller cohort studies, non-English journals were excluded, and case reports as well were excluded. For the purposes of the survey, all members of the American Society of Plastic Surgeons were sent an electronic survey and distributed through SurveyMonkey, evaluating 30 common issues that can arise within plastic surgery and where there's some debate on evidence versus the actual experience. But for the purpose of this study, we'll focus just on a few of those questions. And this was surgeons were given approximately 6 months, and multiple reminders were sent out to them to complete the survey. The initial search yielded approximately 515 studies that met the mesh search criteria. After applying the inclusion criteria, 92 studies remained, and after applying the exclusion criteria, 9 high-quality studies remained that we felt that we had data that we could extrapolate to make some type of conclusion. Nearly 5,300 questions were electronically disseminated, and out of that, roughly 700 plastic surgeons responded. Interestingly enough, when members of the ASPS were polled, over 50% of plastic surgeons continue to employ postoperative antibiotics beyond the 24-hour mark for patients that have elective, clean, sterile operative procedures in which they felt a closed suction drain was even warranted. But furthermore, beyond that, over 40% of these individuals use the duration of drain placement as their rate-limiting factor for when to discontinue actual antibiotic therapy. When you compare this to what the evidence shows from high-quality studies, it seems, in fact, though, that there is no actual benefit in decreasing the overall incidence of infection in patients who undergo these types of procedures once you take them off the benchmark 24-hour postoperative period. A lot of plastic surgeons in general are not willing to place patients that have implant-based reconstruction on, have an arm within a study that does not show that they are using antibiotics because of the potential complication of an infection. Therefore, we just also evaluated the orthopedic literature to look at permanent implants that have potential to also have biofilms, things such as titanium implants, stainless steel, and there's no evidence to show in their literature as well that there is any type of decreased association of infection if prolonged antibiotic therapy is placed. Also, we looked at tissue expander to permanent prosthesis exchanges, breast reductions, and axillary procedures. So in general, it seems in fact that it is safe to not place patients on prolonged antibiotic duration when they have a CDC class 1 type of surgical procedure, which is clean, elective, sterile. This certainly gives us the opportunity as plastic surgeons for best practice guidelines in which we can actually do a few things, and that is hold ourselves to a higher standard in not using unnecessary antibiotics, which will also then, of course, decrease selecting for multi-drug resistant bacteria and infections in an otherwise clean operation with healthy patients. Thank you all again very much for the opportunity to present.
Nice paper. I hope both of these are submitted to ASJ for publication.